One of the aspects of management of complex intra-articular distal radius fractures is the question, can you do an adequate stable fixation of a dorsally displaced intra-articular impacted fracture with an intact or non-displaced volar cortex? In short, a volar plate applied to this type of fracture may or may not be able to support the reduction of the dorsally displaced components. Our hypothesis is that this can be done. Using the experience of the ICUC app, which has documented a large number of distal radius fractures, all treated by a single surgeon, all documented with pre- and post-operative CT scans and followed for 1 year with careful documentation of both objective and subjective outcomes. We found 14 cases of dorsally displaced intra-articular fractures with intact or non-displaced volar cortices. We've documented these, as I mentioned, from start to finish. Let's look at 2 examples. Here you see a patient, 55 years old, with what appears to be a dorsally displaced fracture that may or may not involve displacement and disruption of the dorsal metaphysis, but we certainly can see from the coronal CT and the sagittal CT an impaction of the dorsal part of the metaphysis and articular surface. We see the intact volar cortex. The CT and 3D CT here shows that intact dorsal cortex with a fracture across the articular surface from radial to ulnar side. The carpus is slightly displaced, and one can argue that maybe there's an impaction here, but it's certainly hard to appreciate. Yet when we take the fracture being reduced, you see that volar lunate facet now reducing. So while the volar cortex is not grossly disrupted, there may be what might be called a green stick fracture. Here's the animation. Here's the dorsally displaced fracture, and it's reduced. And with the reduction, we see the volar half being manipulated down, which demonstrates a green stick fracture of the volar metaphysis. The volar cortical rim is intact, but the volar metaphysis has been disrupted. And in fact, in seeing these fractures in patients over the age of 55 or 60, one has to suspect that even if it appears that the volar rim is intact, there's a metaphyseal defect or laxity. And we see this again. And look how this is done. We're looking at a volarly applied plate and a dorsal component of a clamp that helps reduce the fracture. This is a radiolucent bone clamp, and if you see, it helps push down the fracture. We look back at the same case, and the volar cortex was relatively intact, but with the reduction, with the use of the radiolucent bone clamp, we're able to restore the radiocarpal alignment and the plate applied in an acceptable position. The ICUC score represents function and pain, and there are 5 gradations to each. Functional limitation, none, very modest, and progressively more functional limitation, and pain, no pain to pain at all times. Every patient followed has documented function and pain. Let's look at the second example. For all intents and purposes, we see the volar cortex intact. We don't see very much on a standard X-ray. We see an impaction of the articular surface. we have a sense that the volar lunate facet is somewhat rotated, the so-called teardrop angle is displaced, and the sigmoid notch and the lunate facet is involved. Once again, the volar rim is intact. The 3D CT suggests maybe there's a fracture line through the metaphysis proximally. The articular involvement goes straight across the articular surface. Restoration with a volar approach and volar plate. Here's the post-op CT, and at 34 weeks, the plate position is by the Soong criteria, who described the safety of plates in relationship to the tendons. And if the plate is adjacent to the bone or just crossing this line, it's relatively safe. And we see what's known as the Soong classification. And here we see if this line, which is from the very volar tip of the distal radius, dropped in parallel to the radial cortex on the volar side, if the plate sits within this line, then it's considered a 0 category and one that has little, if any, risk of flexor tendon rupture. If part of the plate extends just above the line, it may or may not represent a potential risk of rupture. And if the plate sits well beyond this line, it has a more substantial chance of rupture. The meaning of this is once the fracture is healed, one might consider advising this patient to have the plate removed. One might consider cautioning this patient and educating them on the signs and symptoms of flexor tendon rupture. And this patient very likely will not run into flexor tendon problems. At 34 weeks, the function we see here, we find that the functional score is good. The 14 cases demonstrated an unbroken or undisplaced volar cortex. The volar tilt was restored to neutral or positive in 13 patients. And in one patient, there remained a 9-degree dorsal tilt. Overall functions intact. However, we did note that 2 patients developed a flexor tendon rupture in long follow-up. And note the 2 patients that had tendon ruptures suffered both functionally and with pain, highlighting the need to make certain the plate placement is appropriate. These patients in this series were all documented. The anatomic position of the radius, the ICU See functional score documented as well. The importance of that experience was that we saw in relationship to the 2 studies that by Soong and colleagues and by Kitay and colleagues that the plates were prominent in the position of application rather than being related to the volar cortex.
With the belief that more transparency in the practice of medicine will enable substantial progress, ICUC See is launching a cutting-edge app to improve learning of surgical procedures in orthopedics. The app gathers complete, unchanged and consecutive series of surgical interventions. Independent orthopedic surgeons record the interventions from pre-op to functional result to ensure complete recording, including surgical shortcomings. Download the app from the Apple App Store and access for free to a broad library of orthopedic case studies. Try ICUC app and discover a new learning experience.